Good afternoon. I'm going to present a lecture about pathophysiology and clinical understanding of COVID-19 and what about the anesthetic consideration. The objectives include the background of the pathophysiology, clinical picture, anesthetic consideration, recommendation, and home message. What we know about coronavirus, it's not a new disease. Common cold is caused by coronavirus. But there are 3 outbreaks which occurred over the last 2 decades. The first one is SARS type 1, which occurred in 2002. And the second one is MERS, which occurred in 2012. And lastly, SARS type 2, severe acute respiratory syndrome type 2, which is caused by COVID-19. Simply, these are zoonotic diseases which are transmitted from pet, this is a primary reservoir host, to intermediate host. In type 1, SARS, it was transmitted from camel and then to human. While in type 2, which is MERS, type 1 was transmitted from pet into Soviet cat, while type 2 was transmitted from pet to camel and then to human. And this type 2, SARS type 2, was transmitted also from pet, which is a primary reservoir host, to intermediate host, which is pangolin, and this is scaly mammals, to human. Just for our knowledge, the case fatality rate in SARS type 1 in 2002, it was almost 14%, while in MERS, the case fatality was around 34%, and COVID-19, the case fatality is almost 4%. Actually, ophthalmology has a particular role in understanding and announcement about the disease, and this was carried by the ophthalmologist from Wuhan, Dr. Li Welling, who announced the authorities there about the dangers of this disease. Unfortunately, he was arrested by local authorities there, and unfortunately he died. So what about the route of infection? Usually through respiratory droplet or by direct contact with the patient, and sometimes by fecal-oral route. Also, transmission through ocular surface during ocular surgery is well known because of the aerosol generating procedure, and during shedding of the virus in the tears of the patient, if the patient have, for example, conjunctivitis. Incubation period of the disease is usually around 4 to 5 days, 5 to 7 days, but it can extend up to 14 days. And during such periods, the patient could be asymptomatic, and this is a problem that he is shedding the virus during this period and transmitting the disease to the surrounding population. This is the virus. It has 4 main proteins: the spike protein and the envelope of the virus, and then inside this core there is the RNA virus, the single strand RNA of the virus. The virus to replicate, it needs to fuse with the cell for the synthesis of the protein, and this is through interacting with a certain type of cell of receptors, which is angiotensin converting enzyme 2 receptors. And these receptors are highly expressed all over the body, particularly in the nasal mucosa, in the lung, in the GIT, in the heart, and in the vascular endothelial cell. So once the virus fuses with the cell, this process of endocytosis, how the virus undergo synthesis of its protein inside the cell, simply it will go to the ribosome for translation and transcription of the protein. and then reassembly, and finally release of the virus from the cell through a process of exocytosis. And by this time, usually the cell will rupture and it will die. This is how the virus can attack the respiratory tract after transmission from the upper respiratory tract to the lower respiratory tract. It will come down to the alveoli. This is the shape of the alveoli. We have two types of receptors, type 1 pneumocyte and type 2. Type 1 is responsible for gas exchange, while type 2 is responsible for release of surfactant, which is important structure for keeping the alveoli open. It reduces the surface tension of the surface of the alveoli and keep it open. So what will happen when it attack this type of cell? It will attack these cells after attachment with the type 2 angiotensin receptors. Here is the receptors, and this is a viral replication inside the cell. Simply, after replication inside this alveolar cell, type 1 and type 2 pneumocyte, the cell will rupture, and inflammatory process start to play. So we will get vasodilatation in the capillary blood vessel. The macrophage, which is a phagocytic cell in our body, is going to attack the virus and kill. But this phagocyte is going to release so many mediators. This is a cytokine, and specifically there are certain type of cytokines which propagate the inflammatory process: interleukin 1, interleukin 6, and tumor necrosis alpha. And besides this, the release of chemoattractant mediators, so that neutrophil will also travel from the vascular bed to inside the alveoli. And permeability of the capillary blood vessel surrounding the alveoli will lead to release of and leakage of plasma and proteins to the interstitial tissue around the alveoli, so that the alveoli will be edematous and its wall will become thickening, and this is going to impair the gas exchange along the alveoli. So it will start to partial collapse. Beside dilution of the level of surfactant inside the alveoli, so also the surface tension inside the alveoli is going to rise. And during this process, the patient start to be tachypneic and increase the work of breathing. He is trying to exert more negative pressure to reopen the alveoli. But at this stage, the patient start to be hypoxemic, and the leukotrienes and prostaglandin released from damaged pneumocyte is going to change the body temperature. So the heat regulating center in the hypothalamus will be resetted. So patient start to be febrile, and we got rise up to 38, 39 rise in his temperature. Beside irritation of the vasoconstriction, which is bronchospasm, which occur in the alveoli, and irritation of the vagal nerve, which is responsible for the dry cough. So the patient start to be febrile, have irritative cough, and there is increase in the work of breathing, and hypoxemic. Saturation will come, oxygen saturation will come to lower level than expected. This is the shape of the alveoli after the inflammatory process. We got loss of the integrity of the alveolocapillary membrane, thickening in the wall of the alveoli, and finally collapse and fibrosis of these alveoli. This inflammatory process is also associated with spread of the cytokine which are released into the systemic circulation. So what will happen after this? This inflammatory mediator is responsible for the systemic inflammatory response, including the kidney. So the patient start to develop acute kidney injury with rise in blood urea nitrogen and creatinine. Also the liver, we got rise in his in its enzyme ALT, ST, LDH, and release of so many reactive reactant like G-dimer, ferritin, and C-reactive protein. The lung is affected, the kidney, the heart. We can got the patient may have coronary thrombosis because simply the procoagulant factors which are released during the inflammatory process is going to cause microthrombi, and this microthrombi inside small blood vessel and macrothrombi in major vessel. So we may have pulmonary embolism, we may have myocardial infarction, we may have stroke. The patient may develop even mesenteric vascular occlusion. And at the molecular level, these microthrombi, which are formed in the small blood vessel, is going to impair the perfusion in the organ, so that you got a multi-organ dysfunction syndrome all over the body, and this will predispose to septic shock. Usually, the risk factors are those who are old age, diabetic, hypertensive, patient with cardiac disease, and morbid obesity. As I mentioned before, the symptoms could be upper respiratory tract infection, nasal congestion, obstruction, sore throat, irritated dry irritative cough, or productive cough when consolidation start to occur in the alveoli, loss of taste and loss of smell, and the patient may arrive with CNS manifestation like dizziness, agitation, even a stroke, cardiac manifestation like heart failure and myocardial infarction. The clinical presentation usually vary from mild to moderate and severe, or the patient could be asymptomatic. Usually asymptomatic patient can take home treatment, and they doesn't represent a problem to the local medical service, but moderate and severe cases will need hospitalization, oxygen therapy, and even mechanical ventilation. This figure illustrates the extent of the problem. 20% of the patient could be asymptomatic, but in 10% of the patients, they will need hospitalization, and 5% will need oxygen therapy, while around 1% will need critical care service. Laboratory investigation usually includes a reverse transcripted PCR, polymerase chain reaction, serological study for identification of antibody inside during this process. Usually takes 3 weeks, 1 to 3 weeks. So usually it is not the ideal test, but other investigation like CBC, we can identify presence of leukopenia, lymphopenia, rise in C-reactive protein, rise in acute phase reactant like D-dimer, and change in the coactive profile of the patient. This is the shape of the lung during the inflammation. We can identify presence of subpleural infiltrate and even consolidation in severe cases. This lung, by the way, start to be fibrotic after this, and the patient will develop respiratory failure, and this is very severe cases which usually carry very bad prognosis. Identification of patient before surgery is very important. Therefore, pre-anesthetic assessment is vital, but to prevent this, we need to vaccinate all population. Announcement about the need for self-isolation before admission if the patient had mild or severe cases or even mild cases. Wearing personal protective equipment and hand hygiene, and to dedicate pathway inside every hospital to separate person who had infection from those who don't have infection, and minimizing stay of patient inside the hospital. The WHO have 3 points to avoid transmission of the disease, just to suppress the transmission and provide optimization of the patient, and to minimize the impact on the medical health service, social and economic activities. The perioperative complication is high and mortality is high, so that the 30-day mortality in patients who had COVID, unidentified COVID, or those who even have COVID and underwent surgery after infection, the odds ratio is almost 3 times for those have respiratory problem or have COVID in comparison with those who don't have infection. So pre-anesthetic assessment is very important, including identification of patients who are asymptomatic from those who don't have symptoms, and classification of patient between mild, moderate, and severe. What we will do, shall we do screening for all the patient? This issue is always debatable. Some hospitals require to do PCR, CT like this, but usually if the patient is asymptomatic or you are going to examine the patient for the first time, at least you need picture, you need to do CBC and C-reactive protein. General anesthesia, choice of anesthesia is always debatable issue. Shall we go for general anesthesia or regional? Usually regional anesthesia is the most safe, because if the patient has any respiratory complication, the post-operative stay in the hospital and mortality rate is high. So we have to wait at least 7 weeks for those who have moderate or severe infection, and to proceed for regional anesthesia if possible, and if the patient has a respiratory problem. Sometimes the patient may ask you, I got first or second dose from vaccination, shall I proceed for surgery or no? The American Heart Association usually recommend to wait 2 weeks from the last dose. But because both surgical stress and general anesthesia have its impact on the immune system of the patient. But regional anesthesia, to less extent, it attenuates the pressure response on the patient, so it is the most safe. What is the recommendation? Just wait 7 weeks from infection if you are going to proceed for any surgery, just to announce for the vaccination, and wearing the personal protective equipment. This is in short, in brief, what we can be confronted with question and how to deal with this. Thank you and stay well. Thank you.